Welcome to OncoPharm. I'm your host, John Bazar. I'm a professor of pharmacy practice at East Tennessee State University, and this episode is sponsored by Kelly Seed PharmD, an oncology education company for pharmacists. I am back from a very restful, restorative week of vacation, and got quite a bit to talk about. I'm going to get right into it with a publication from the New England Journal of Medicine from a couple weeks ago, which is 10-year outcomes after CAR-T therapy for B-cell lymphoma. So this is the kind of follow-up just for B-cell lymphomas of tisagenlecleucel, or TIS-cell. This was the first CAR-T product approved in the United States, and this was in August of 2017. And I've done this with a lot of the landmark studies, like this study was published in 1983, what was going on in 1983. I haven't done that for any recent studies, but we're a decade into the CAR-T era, so it gives me an excuse to go back. So in August of 2017, the number one movie that month in the United States was Annabelle: Creation, a movie I do not remember or I did not even know existed. Number 2 was Dunkirk. Love Dunkirk. Number 6 was Girls Trip. Very funny. The top song was Despacito. All right, that's enough trip down memory lane. So what's notable about this is it is long-term follow-up of CAR-T, and which is notable. This was not a randomized control study. These were the first humans to receive this drug with B-cell lymphomas. There's only 38 patients, 24 of whom had large B-cell lymphoma, 14 with follicular lymphoma. And I'll just go through the abstract, and I'll tell you my first thought when I read this abstract. I was kind of just scrolling in the morning, drinking coffee, and I just kind of skimmed the abstract on vacation, what my abstract thoughts were, and then went back and read the study, going through it. So, median follow-up of 10.1 years, no relapses that occurred beyond 5.4 years. It tells me that exactly someone recurred at 5.4 years, a small sample size, but that does give some credence that this might be curative in some folks. Which at this time, follicular lymphoma, we've never thought was curative. And for diffuse large B-cell lymphoma or large cell B-cell lymphoma, if you didn't go to an auto transplant and relapse, we didn't think it was curative. Now that's changing with CAR-T, of course. Let's see. 10-year overall survival was 17%. I thought that was kind of low. And that was for follicular lymphoma. 50% with follicular and 17% with B-cell lymphoma, 29% overall. Secondary primary cancer developed in 21%. I thought that was pretty high. 10-year non-relapse mortality, 18%. I thought that was really high. B-cell aplasia persisted in about half the patients, 44% with that had a long-term response. We kind of thought that. It's encouraging that some folks were able to have normal B-cell recovery and able to have immune globulins produced on their own. But I was like, I bet a lot of these patients that had all this non-relapse mortality, this is probably a very heavily pretreated population, more heavily pretreated than our current CAR-T patients. And that ended up being the case. So if we look at our baseline demographics, half of them had already had, baseline demographics, those who had a long-term response. That's just 12 of this patient population. Half had an auto transplant. Median lines of prior treatment were 4. What is maybe interesting is that of those who had a long-term response with follicular lymphoma, there were no relapses after 2.7 years. That's with a median follow-up of 10 years. Now, you're going to have late relapses of follicular lymphoma, but this is a disease historically we have thought is incurable in any setting. And now, I think it's fair to ask the question, could we cure folks with follicular lymphoma with CAR-T? There was some long-term anemia and thrombocytopenia. One of those patients did have a pre-existing autoimmune disorder. Secondary primary cancer happened at a median time of 4.7 years. 8% of them had treatment-related AML. Then there's some prostate cancer, which you probably don't attribute to that. They do say that the 10-year incidence of second primary cancer was 21%, and they estimate that for an age-matched population, it would have been about 11%. So almost double the risk of second cancer. I think that is in a patient population that a lot of them had high-dose alkylating therapy as part of their stem cell transplant. But certainly something to look for as CAR-T moves earlier in treatment. What are those, that 10-year, that long-term non-relapse mortality and second primary cancer risk? That's going to be an important thing to continue to follow, and this gives us a roadmap for looking at that. They did some fun statistical analyses if you're interested in that, and how they adjusted for competing risks, right? So if you have a progression event and then a death event, say 2 days later, it counts as a progression event in your PFS, but you get the progression followed 7 years later by a death. That's a very different progression event than one. So that there's some novel, or maybe not novel to me, statistical analysis they do in this that might be worth some of you checking out. Okay, the next publication I have to talk about is LightSpark 022. This is adjuvant pembro and belzutifan. I talked about this with the FDA approval, I think in the prior week before vacation. So this is the publication here. I do just want to, as someone who has been a doubter of this regimen, if you look at the subgroup analysis, you don't see that the benefit in M1 disease, or those folks who had metastatic disease resected, that is driving the benefit. The benefit seems to be across all patients, M0, M1, NED. Not a ton maybe learned that was new that we learned from this. We did know there's a lot of anemia. What is interesting is some of these folks in the study, their anemia was managed with ESAs, which in the U.S. we don't use ESAs, erythropoiesis-stimulating agents, in potential curative diseases because it can make it worse. So it's curious they did that in the adjuvant setting. Presumably that was not in the United States. But maybe what's notable about this study, or what we can learn from this publication that we didn't already know, is when you read all these studies, and the primary endpoint is disease-free survival, the time from randomization until you have disease, because there's no evidence of disease in any of these people at the time of enrollment. So, suddenly there's disease or they die, all right? And a lot of these disease-free survival, progression-free survival, we have our RECIST criteria, but it's subjective, right? So you see a new, I don't know, you do a follow-up CT scan, you see something in the lungs, do you go biopsy to confirm it's there or not? There's some subjectivity there, especially with progression. Is this really 23%? Is it 27%? Is it 33%? What is the size increase, decrease, etc.? So to control for that, and this is a sound methodology, a lot of studies, most studies, will have the investigator analysis. So this is the physician of record for the patient looking at the scan saying, all right, this is progression or not. This is disease recurrence or not. And then they have a central review that's usually blinded, okay? So here are the hazard ratio for DFS, and the investigators is 0.72. For central review, it's 0.76. So the benefit is not as much in the people not invested in patient care. Look at this. And so there are actually, this is 900 people on each arm, very large study in the adjuvant setting. So the disease-free survival event numbers go up by 19, a total of 19 in the experimental arm with belzutifan, and by 6 in the pembro arm. So the investigators, they're tied to the patient. There's a little bit of physician bias here where they are reluctant to maybe give bad news and say, hey, your disease is back, okay? Now, the overall survival, there's a death certificate or there's not. That is very objective, and why that should still be our gold standard, and why our disease-free survival, which is the primary endpoint in a lot of these adjuvant studies, can be useful if there is a huge impact size. If there's a huge impact factor. This is a mild to moderate, impact factor, I think, that we're seeing, or size of impact that we're seeing here. So I think the jury's still out, waiting to see more follow-up to see if are we curing more people with this, with our OS benefit. Okay, so a lot of listeners to this pod, they're just trying to learn oncology, whether they're new to the specialty or just trying to deepen your understanding of a particular disease state, like renal cell carcinoma. To help, Kelly Karlstrom, founder of Kelly C. PharmD and the ELO Collaborative, created the Learning Oncology Companion. It's a free template that provides a structured framework for learning any cancer type, helping you organize key thoughts like risk factors, symptoms, biomarkers, staging, and treatment. Download the Learning Oncology Companion using the link in the show notes. Okay, the next approval from the FDA I have to talk about. If you Google FDA oncology approvals, you won't find it because this is a cellular therapy. This is Orca-T, which is what the company calls it. The company's name is Orca. By the way, orcas, favorite mammals, right? Called killer whales. I think they're actually dolphins. Did a project on them in 3rd grade. Know a lot about Orcas. Anyway, so this is an approval in the allogenic stem cell transplant population. Now, if you try to look for this drug, it's too bad we couldn't call it Orca-T. Now, I know there's some bias because that's the drug company, but this is the official title if you look it up in a drug database. Is allogenic T regulator cell-based immunotherapy with hematopoietic stem cell, stem and precursor cells and T cells. -VLDQ. I mean, it's just crazy. Is that what's going to be on the label, on the vial? It's nuts. So I'm going to refer to it as Orca-T, which is what is in the pre-approval data. So this is in blood. This is Orca-T versus allostem cell transplant. This is Precision T. Now, I am not a cellular therapies pharmacist. I haven't done bone marrow transplant since 2009. This is a relatively modest study, 190 patients roughly, with acute leukemia or MDS, and they're randomized. These are matched donors, and they're randomized to either standard of care, whether you get allogenic stem cells, a myeloablative conditioning regimen, and then tacrolimus and methotrexate for GvHD prophylaxis. Appropriate. I won't weigh into should these folks have been getting post-transplant cytoxin. Okay. Primary endpoint is survival from moderate to severe GvHD, which was much better. The 1-year estimates for chronic GvHD free survival was 78% with the experimental arm versus 38.4%. Okay, overall survival 93.9% with the experimental versus 83.1% with conventional therapy. So pretty sizable difference, and these numbers are statistically significant. What is worth talking about maybe for generalists, as I kind of talk about the immune system a lot on this podcast, it seems, as it's so important to oncology, is that, and this is in the Blood publication, but allo stem cell transplant donor-derived polyclonal Tregs, which are CD4 positive, CD25 positive, and FOXP3 positive. These regulatory T cells modulate T cell activity and can help decrease the risk of graft versus host disease. So I talked about this a couple weeks ago about how the complexities of our immune system. And so before, we had to get all these T cells out of there because those T cells could contribute to graft failure. They can contribute to graft versus host disease, all right? So get as many T cells out of there. Well, there are some T cells we'd like to have there, these regulatory T cells. So the way this product works is on day 0, you are getting your stem cell infusion, right? Your standard day 0, your hematopoietic stem and progenitor cells, you get that infusion on day 0. Also on day 0, you get infusion of Treg cells. Now these are allogenic. They are from, are they allogenic? No, they're from the patient. They're individualized. And then on day 2 and 3, you get conventional T cells, okay? So, no, it's an allogenic T cell, yeah. So it's interesting how they're doing this. It is, I think, further underscores that we are learning more and more about the immune system. Okay, so I had to pause and reread about this because I read about it a few days ago. They're the donor stem cells, the donor Tregs, and the donor conventional T cells that are given later. So what is different about this approach from this company is you're getting 3 infusions, right? So you're getting your normal stem cell infusion, you're getting a Treg infusion on the same day, and then you're getting conventional T cells on days 2 and 3. So looks to be a nice step forward. Okay, now on to something I feel more confident talking about. And this is from JCO this week. This is polatuzumab vedotin plus rituximab gemcitabine oxaliplatin. So PolARGo in relapsed refractory diffuse large B-cell lymphoma. Results from the phase 3 randomized, how would you say this? PolARGo. Would you say PolARGo, which I think is what the company would want to say, or PolARGo, like Key Largo, Montego, baby, why don't you? This is the question, or this is the line in the song Kokomo by the Beach Boys that I first thought of as soon as I saw this. So this is PolARGo versus Argemox, which is a reasonable relapsed refractory diffuse large B-cell lymphoma regimen. It's a very well-tolerated regimen. It's not a regimen we think of as something we want to give a lot of folks to bridge to transplant. And in fact, one of the inclusion criteria are these are patients are deemed ineligible for an auto stem cell transplant. This goes, if you thought about this study, if you design this study, you would think, man, this is probably going to be better, but it's probably going to be more toxic. There's a reason in the PolARGo protocol, you don't give polatuzumab vedotin and vincristine because they both cause neuropathy. Well, here we're given polatuzumab vedotin and oxaliplatin, drugs that both cause neuropathy. And we're given the same oxaliplatin dose, 100 per meter squared, that the control arm is getting every 3 weeks. So it's not surprising kind of what we see from this. And just if you don't know, it's standard dose rituximab. Gemcitabine is 1,000 per meter squared, milligrams per meter squared on day 1 only, and then oxaliplatin 100 milligrams per meter squared on day 1 every 21 days, and then standard polatuzumab on top of that in the experimental arm. They all got GCSF prophylaxis and PJP HSV prophylaxis. And we do see, some pretty big, improvements here. We do see, a significant improvement in median overall survival, 19.5 months versus 12.5. That's a hazard ratio of 0.6, pretty nice impact effect. 95% CI was 0.43 to 0.83. We see improved progression-free survival. We see a CR rate of 40% versus 19%, so doubling the complete response rate. These Kaplan-Meier curves for OS separate, and they stay separated throughout the duration. There's a more sizable difference in progression-free survival. So it is a very, very active, regimen. But it is significantly more toxic, in my opinion. So we see that peripheral neuropathy is 57% versus 29%, including 4% grade 3 or 4 peripheral neuropathy, more diarrhea, including 7% grade 3 or worse diarrhea with the experimental arm, more transaminitis, a moderately improved transaminitis. There were, I don't know what, this should be the first paragraph of the safety, but it's the third paragraph in the safety section, which is grade 5 AEs, which would be written as treatment-related deaths, were more frequent in patients receiving PolARGo, 11.7% compared to 4% in the control arm. And most of these were infections, and they say a lot of these were COVID, but, there's measles outbreaks in the United States now, so there's infections everywhere. This was an older patient population, more than a third were over the age of 70. Kind of makes sense if you're going to make them, if they're not going to be candidates for transplant. Interestingly, as far as next treatment, some of these folks became transplant eligible after treatment. Now, some of the reasons for transplant ineligibility could have been they didn't have a response to the prior regimen, which does make sense why some of them went on to transplant. One thing that is curious is we know from the PolARGo study, or PolARGo, is that we seem to see more relative benefit in the activated B cell subtype of diffuse large B-cell lymphoma compared to germinal B-cell type. We don't see that here. We see this, basically the forest plot's the same for ABC versus GCB. Now, it is worth noting that more than, look at that, I'm doing quick math here, more than about a third of patients in this study were unclassified by cell of origin. So an incomplete thing, it could be that the cell of origin thing is just spurious, but that's not my belief if you look at the follow-up data for PolARGo. So that is what I have for you this week. Thank you so much for listening. You can follow me on Twitter at PharmDeacon, but the podcast at UncleFarmPod on various social media platforms. I'm not that active anymore. I'm an old man. Anyway, but thank you for listening. And until I talk to you again, remember, doses matter.